Welcome to the third episode of Turning Points, GSAR's first podcast series on rehabilitation and reintegration of returnees from Northeast Syria. My name is Isabela Ottoni and I work here at the Portfolio Management Unit. In our first two episodes, we set the scene, the camps, the families, the work of preparing someone for the journey home. Today, we are looking at something that lies at the heart of it all, and that is arguably the most important part of rehabilitation and reintegration work. We are talking about mental health and psychosocial support, also known as MHPSS, in rehabilitation and reintegration. Earlier this month, GSAR convened a global community of practice, bringing together practitioners, researchers, and policymakers from around the world exactly on this topic. Practitioners from Kenya, Iraq, Mali, Kosovo, and Kyrgyzstan came together with colleagues from the United Nations Peacebuilding Support Office and academic partners from the Institute of Psychology of the University of Pristina to share what they have learned and what works, what does not, and what the world still gets wrong about MHPSS. This episode builds directly on that conversation. I'm joined today by three guests who each bring a distinct and essential perspective. First, Mario Nascimento, who works at the United Nations Peacebuilding Support Office. He currently works on disarmament, demobilization, and reintegration programs and brings a global and policy view to this discussion. Then, we are speaking with Dr. Oscar Githua, a forensic psychologist based in Kenya with over 25 years of experience working directly with individuals disengaged from violent extremist groups and with communities affected by that violence, bringing a clinical and frontline perspective. We also welcome today Hadeel Mohammed, who works with the United Iraq Medical Society for Relief and Development, where she supports returnee women, children, and families through psychosocial programming on the ground. She brings a civil society perspective and the daily reality of delivering this work. Welcome, all three of you. It's a pleasure having you on this podcast today. Thank you very much, Dr. Oscar Githua, for joining us today. Dr. Githua, you have been working in this field for a long time. So could you please paint us a picture of what it means to do mental health and psychosocial support work with people disengaged from violent extremist groups and also communities affected by violence?
Thank you so much for having me. It's a great privilege to be on the podcast. I think you're doing a good job with it. In Kenya, just as recently as 10 years ago, very few people would have imagined that this is a possible thing to do. It's a marked change from the previous thinking, which prioritized the security approach while handling people who are disengaging or who are members of VEOs. We have two contexts within which we do our work. First of all, when the client is in custody, when they're in prison serving a sentence, and secondly, with the clients who are in the community. This is as a result of the NSCVE 2016, which is the national policy which created the psychosocial pillar, which opened the door, although with a lot of caution for us, of course, to work directly with the clients. And we've been able to work not only with the clients themselves, but with their families, their mothers, and also community members who are affected by this phenomenon. Through working with them, we found that there are a lot of mental health and psychosocial challenges that they have. For example, PTSD and trauma, depression and anxiety, family issues, and gender-based violence. The work is challenging, of course, because it requires a special kind of patience, dedication, and consistent learning. And the field is rapidly changing, and we know that the vulnerabilities that drive young people into radicalization are changing. The good news, however, is that the work that has been done, for example, with the SIRR program with GSAF has increased the community's understanding of VE and has resulted in them being partners in healing and building together. And finally, my experience is that communities are healing and that lives are changing for the better, which is helping us to build a lot of hope, security, as well as peace. Thank you so much.
Often, mental health is associated with a psychologist, a medical, very clinical setting. But at the community of practice that you joined a few weeks ago, you described that communities with the faith leaders, teachers, neighbours, for example, have a crucial role in MHPSS interventions. So, how would you describe the role of a whole of society approach in MHPSS work? And how would you say to better integrate other sections of the society in this work?
Well, like you've said, I mentioned about faith leaders and community leaders, teachers, neighbors, and other stakeholders as partners in this work. And the very important note I have to make is that they are in the community and they are at the centers of credible voices that the youth identify with. In any case, they live in the same communities with them and they've watched them growing up from when they were young. So what they do and they help us with in the MHPSS work is that they act as an early warning system, because they would be the first ones to notice any changes in the young people who are being radicalized or who are vulnerable to being radicalized. And if we continue to equip them with basic MHPSS and trauma intervention skills, we are able to handle the basic concerns that plague vulnerable youth. Psychologists and counselors, including other health professionals, like you've mentioned, the psychiatrists and medical clinicians, they're very critical in this work. However, at a more advanced stage, when specialized services would be required to be given to a young person or to a client. The ideal design of how to implement a whole of society approach in MHPSS would be to require us to follow the intervention pyramid, with basic interventions at the bottom and specialized ones at the top or at the apex. This design would allow for more segments of communities to be involved at the bottom of the pyramid, with more specialists being involved at the higher levels. This means that you can actually incorporate other things like schools, other institutions, and places where young people appear naturally to be part of our intervention.
Hello, Hadeel. Welcome and thank you for joining us today. You work directly with returnees, with women, children, other family members as well. The idea of stigma comes up repeatedly when it comes to providing mental health and psychosocial support, and also when we speak generally about working with returnees as one of the greatest barriers they have to recover, and also a very hard one to address. So when you work with them, in our experience, what does stigma actually do to a returnee, and what does it take to deal with stigma also within the communities?
Regarding the stigma against returnees, the issue is not related to the fact that they are returnees perceived, but rather because they are perceived as families associated with ISIS members. Usually, communities completely rejected interacting with these families, as many people had lost their sons, husband, relative, or lover, once due to the action of ISIS. Consequently, these families were often viewed as criminal families, even though they themselves had not committed any crimes, and that those responsible for such crimes are now being protected and held accountable under the law. The awareness session focusing on social reintegration and the prevention of violent extremism, communities gradually come to understand that these families, particularly children, should not be blamed for the action of others. Many of these children were born without any knowledge or responsibility for the circumstances that lead their parents or relatives to join ISIS. They deserve the opportunity to continue their life normally and to grow up as active members of society. I will give you, for example, what we had faced and what we are doing. One simple yet powerful example occurred in primary school when we attempted to reintegrate a child into education. One of the teachers initially refused to accept the child, explaining that her husband had been killed by ISIS during the occupation of Salahuddin Governorate, and that, in her view, the child belonged to the families of those responsible. She stated that she could not accept teaching him. Following a series of dialogue sessions with the teacher, other members of teaching staff, the school administration, the director of education, and tribal leaders in the area, we successfully in overcoming this barrier. the child come to be recognized as an innocent individual who bore no responsibility for past events. In fact, when the incident that had affected the teacher family occurred, the child had not even been born. Today, it's our responsibility as professionals working in education, health, and psychosocial support service to foster positive values and healthy attitudes among children so that they can successfully adapt and integrate into society and become active members of their communities.
Thank you so much, and thank you also for sharing this example. It's very touchy and it's very important what you are doing. Hello, Mario. Thank you very much for joining us for this episode. In the event, you drew a distinction between MHPSS as an end itself and also versus MHPSS as an enabling intervention when it comes to R&R. If you could explain further this distinction and also mention to our audience how some examples in practice on how MHPSS can be an enabler to other interventions, it would be great.
MHPSS is one among many interventions that can contribute or even lead to the end of conflict or to at least mitigate the sources of violence. MHPSS can play a significant role across regions, across communities, across groups. I think also MHPSS combined with other interventions can ensure the sustainability of economic and social and political reintegration. A key example is that in contexts where we are promoting income-generating activities or job placement, for example, it's critical that not only individual have an opportunity, economic opportunity, for example, but at the same time it has to be accompanied with psychosocial support so that he can have the support to overcome any challenge, any personal challenge, any economic challenge. By providing the psychosocial support, you maintain a level of assistance, for example, that enables an individual to fully engage in economic activities or even political engagement and so on and so forth. MHPSS also allows a more tailored intervention according to the needs of each individual, moving beyond the lump sum, for example, or general support that could be provided. MHPSS really allows identifying or understanding what is the life history, what are the challenges, the personal challenges or personal needs, for example, and how that can be addressed in the long term.
What does sustainability look like in mental health and psychosocial support? And how can international actors better support local organizations without creating dependency or duplicative efforts?
Yes, genuine sustainability in mental health and psychosocial support means that these services become a nature and integrated part of the health and community system rather than a temporary response linked only to short-term funding or emergency situations. It also means building the capacity of local professionals and communities themselves so they can continue providing support even after international projects come to an end. From our perspective, international actors can better support local organizations by investing in long-term capacity strengthening and by engaging local organizations as genuine part in planning and decision-making rather than only implementing initiatives. Coordination among the stakeholders and aligning efforts are also essential to avoid duplication and ensure that interventions complement the actual needs of communities. Ultimately, the goal should be to power local institutions and communities to lead the response independently and sustainability rather than creating long-term dependency or external support.
What would you say are the minimum they should understand and commit to MHPSS when it comes to rehabilitation and reintegration?
The minimum is that practitioners, national authorities should understand that providing MHPSS is a shared responsibility, right? No single entity can deliver all aspects that are needed. When we are trying to develop or to support or to design MHPSS, we have to acknowledge also the role that other entities such as schools, parents, family, the individual himself, the responsibility that he has to be committed to a process, to a healing process, for example. So providing MHPSS in a sustainable manner obviously requires investment, it requires programmatic activities, it requires engagement of the line ministry and so on and so forth. But it shouldn't be seen just as a technical, a clinical endeavor. There is a level of individual, political, societal commitment, for example, that's why I stress in that it's a shared commitment. The last thing that I would say is that there is no simple solution to complex issues, for example. So there is no shortcut for MHPSS. If we really want to be successful, the design, the consultations, the engagement with different stakeholders is critical, I would say. Always with this perspective of shared responsibility.
Mario, Dr. Githua, Hadeel, thank you very much for sharing your thoughts and experiences with us today. And if there is one thread that runs through everything that we discussed today, it is this. Mental health and psychosocial support is, or at least should be, at the foundation of R&R, and not an add-on. Without it, every other intervention, legal, educational, economic, etc., is being built on a ground that has not been allowed to settle. To our listeners, thank you very much for tuning in. We will be back with another episode next month. Find Turning Point on Spotify, Apple Podcasts, and YouTube. Subscribe and share, and see you next time.